go into depth for some specific areas. So here I made the agenda for today. Today, it's only 45 minutes. Why are we using EPAs now in the Netherlands? It's fully introduced in all different specialties now. Is CBME not good enough? I will try to answer that as the first main question. Then I will go to some critical issues when using EPAs, and that's supervision levels and entrustment decision-making. I will shortly go into how you make an EPA-based program or curriculum. And then finally, some words about the workplace-based assessment and summative entrustment decisions. Now, why EPAs? Is CBME not good enough? I remember when I was in training for an internist, and that's about 25, 30 years ago, I don't remember if we had a real program. It was more like see one, do one, teach one. But it was not until 1973 that a competency-based framework was developed. But as you all know, the CanMETS competency framework was only introduced in the year 2000. Now, why did we introduce CBME? It's the dissatisfaction with what we had with quality of care, dissatisfaction with the training modules, and also dissatisfaction with the supervision and patient safety issues, as you probably recognize. Now, what is the essence of CBME? CBME is education aimed at a standard level of proficiency of all graduates. So critical features for CBME, as you're using right now in clinical practice or in student education, that you need to have a clear description of what is the standard of a good physician or of a good specialist. And then if you have this description of the standard, then assessment of all medical trainees should be using these standards. And it's very important to realize that in CBME, the competence of a learner and not the time is the primary reason to finalize training. So maybe you can think about your own program, residency training, or a curriculum. Do you have a time fixed curriculum? Or do you have a flexible system? Because actually, if you want to implement CBME, then it should be a time flexible, individualized program. And I know that's really a challenge in clinical practice to have a flexible program. So another reason why CBME was introduced is think about this question for yourself. Would clinical educators trust all graduating trainees with their own family members as patients? That's a difficult question, you know. We did actually interviews among residency program directors, and many of them can recollect cases, so residents signing off for completion of training, even if not completely confident. And maybe you can recollect that also in your own practice, also with medical students. Now, why is it that program directors fail to let a resident fail? It's actually a failure of the program director to fail a resident. Why is that? Well, a lot of time it's like, oh, you know, your time is up. And in the Netherlands, for example, if time is up, then there's also no money. So then it's easier to say, oh, I think you will learn it when you practice a little bit more, and kick them out of the program. Now, another problem, as a program director, I recognize that very much, is that I think in clinical practice, I don't know if this is really a resident that should be certified to being an internist in my case. But then there was no valid documentation to back up my gut feeling. Then what do you do? And with medical students, I also know that if you say to a student, you fail, then there's a lot of trouble you have to go through what to do next. Because in a lot of contexts, there are no remediations, there are no tools to handle. What should I do now? I want to fail this student or resident, but what's next? And when we doubt, when we are unsure, we unfortunately err for the benefit of the trainee instead of thinking of the patient. So the imperative of CBME is reducing false positive decisions to graduate trainings for unsupervised practice, because that's what we do when we graduate them. Now here you see this competency framework and you probably recognize it. Huh? The doctor, the 7 roles in the CanMEDS competencies, and I assume you all know them. But then what happened with the framework? We have tended to break down all the different competencies. And that's logical, right? Because as a communicator, as a doctor, you're communicating with nursing staff, with family, with patients, with colleagues, with trainings, and that all questions different attitudes and different competencies that you need to communicate well. But then it goes further. When we talk to patients as a doctor, as a communicator, we also want to test, do you do that in the right way when talking with patients to explain medication? Or when you're talking to the elderly patient? Or when you have to break bad news? And so what happens with the CanMEDS competencies, that all the competencies were broken down into subcompetencies and subcompetencies. And in the end, and that's really true, we found ourselves with over 700 subcompetencies. And of course, we are now computer, and we don't want to end up with huge checklists to be checked before we can say that a student or a resident meets the standard of what he has to reach to become a doctor of a specialist. So we got ourselves in big troubles by subdividing all the competencies in sub competencies. So the framework was generally accepted, but it became too analytical and detailed. A lot of competencies got rather abstract and general, and the clinical teachers, with the amazing amount of competencies, struggled with the assessment. So there's a lot of publications that doubt about the accessibility of the competencies in clinical practice. So these are all articles. Then there are many more. So I was very, very proud, of course, maybe you recognize, the founder of the EPAs, and that is Olle ten Kate. He's also an internist, and he's working in the University of Utrecht in the Netherlands. And he actually thought a long time of how can we bridge the gap between theory, all the competencies, and clinical practice. And the EPAs actually are the missing link between the competencies that are defined by the person and the clinical needs, the task that needs to be done in clinical practice. So here you see the definition of an entrustable professional activity. EPAs are units of professional practice, tasks that may be entrusted to a learner or a student or a resident to execute unsupervised once he or she has demonstrated the required competence. So what we do here is actually shift in focus from individual competencies to the work that must be done. Here I show it to you. Oh, another slide. The 3 letters of EPA. Entrustable, that refers that the activities require trust. By whom? By colleagues, by patients, by the public. The P for professional is to indicate that activities are confined to occupations with extraordinary qualifications and right, like in medicine. And the activities are just the tasks that need to be done in clinical practice. Now here I show you again the difference between competencies versus APAS and how they are actually interconnected. Because here I indicate that competencies are actually person descriptors. Competencies tells you the knowledge, the skills, the attitudes, and the values of a person. And competencies describe the ability of a person to communicate, to show professional attitudes, to show manage abilities. And actually, if you look at the definition of competencies in the Oxford Dictionary, it says competencies are the ability to do something successfully or efficiently. It tells you something about the person. Now let's go to the EPAs. The EPAs, they are work descriptors. They are units of professional practice. So it's leading a family meeting, or it's inserting a central line, or it's discharging a patient. So EPAs refer to something that is done successfully or efficiently. I hope you can feel how the competencies are actually integrated in EPAs. Because this is what we are talking about. We have a task that needs to be done, and it should be done by a person who has the competencies to do the job. And the question is, do they fit? So the EPA framework is a more holistic kind of approach. Here you see again all the roles, the competencies of the individuals, and you usually need an integration of several competencies to accomplish an EPA. And for example, if you take history taking as an EPA for a student, then of course he needs a good amount of communication, but he also needs to be a professional in interaction with the patient. But you should also be a medical expert, because you need clinical reasoning to be able to do a history taking. So EPAs need an integration, multiple competencies. And this is how you could look at a program of interaction of the EPAs with the competencies of the persons, like I just explained to you. And when we look at the assessments, then we focus on the EPAs. And in the assessment, we do not focus on the competencies and all sub-competencies. We look at how the EPA is performed. And if there's trouble, then you can divide the activity in the different competencies that you need to perform the activity. So we have made an operational definition of competence. When a professional activity is mastered at a threshold, you need trust and you have to act unsupervised. And competence is thereby a certain stage in a developmental continuum. Now let me try to explain that a little bit easier by making use of the driver license experience. Because when you learn how to drive a car, there is a growth of competence over time. And then you see that the learner is going from a novice to advanced learner, a competent learner, a proficient, and an expert. So during the training time, at a certain time, and it's nice to see here that competent is right in the middle of the continuum, but at a certain time, you get your driver's license and you're ready for unsupervised practice. But if you go on with deliberately practicing, then you grow further into a proficient and into an expert. Now we can translate this to the growth of competence over time in EPAs. Here we have one trainee, and that one trainee has to accomplish several EPAs. And here you see when the training is ended, then here, where's my cursor? My cursor is gone, yeah. And here you see when the trainee is ready for unsupervised practice. For another EPA, it can be a much easier task, and the trainee can be certified for unsupervised practice at an earlier time. Here you have an example, APA 4, for an EPA that is started only in the second year. And so you can see the growth of competence over time can be different for the different EPAs. But that's no problem. The justified entrustment decisions can be various. We do have to be careful because there could be EPAs that you meet the standard at the end of your training time. But if you do not practice them anymore and train them anymore after your graduation, then there can be loss of trust in this EPA. And this is something that, of course, as a professional, we have to take care that that's not happening. And when it's happening, it's no problem, as long as you know it and you take action on it. Now here I show you two lines of one EPA by two different trainees and how they can differentiate between the growth in competence over time. So the blue trainee needs much less time to be ready for unsupervised practice compared to the red trainee who needs more time for training to meet the standard of a doctor. So here I show you that with an EPA-based program, it's an individualized program because every trainee has his own speed and knowledge development to eventually meet the standard of the doctor, of this medical specialist that you want him to be. And that because we are different in growth of competence, you also will reach unsupervised training at different time levels. So you have a flexible training duration, and this is what we call in the Netherlands individualization of the residency training program. And every resident goes with its own speed. Now, I assume that you already guessed that critical issue when introducing and working with EPAs is the supervision level and the entrustment decision making. And I want to share with you the difference between ad hoc and summative entrustment decisions. Well, I wish it was as easy as this mother bird who decides to kick out her little birdie out of the nest. But the entrustment decision making in an EPA setting, we use now 5 levels of supervision. And these levels reflect increasing trust we have in the trainee autonomy. So here are the 5 levels. The first level is be present and observe, and there's no permission to enact the EPA. The second level is practice the EPA, but with direct proactive supervision. The third level is practice the EPA with an indirect reactive supervision. And then at level 4, there is distant oversight. So it's unsupervised practice is allowed. And level 5, finally, then the residents, for example, can supervise junior learners. Quickly have some figures which you can imagine that this level of supervision is observation only. Here is the boss behind the woman with the scope. It's a direct proactive supervision. And here it's called indirect reactive supervision. And this is what usually happens at night when the resident is alone and the internist is sleeping in his bed. It's this distant supervision. And at the end, being a supervisor for juniors. Now, here I show you an example of how the skills may be slightly adapted and shows variation for an undergraduate education program. And there, the skills may have been subdivided, broken down into more skills. So for example, here, the direct supervision can be subdivided in 2A. Then the EPA is conducted as a co-activity with a supervisor. And for 2B, the EPA is conducted alone with the supervisor in the room. And he or she can step in immediately as needed. For indirect supervision, here you can also see that there's a subdivision in 3A, 3B, and 3C, depending if all findings are double-checked in A, or key findings are only checked in B, or when decisions and findings are only discussed on the student's request. So there are some variations in the skill you can use. Now, as you already feel that entrustment decision and supervision are really intertangled. And assessment in an EPA-based program aims at entrustment decision for a designated level of supervision. That's the main thing. So in fact, instead of talking about supervision levels, you can also translate that into the main levels of entrustment. So the level 1 of supervision is then that the learner is allowed to be present and observe. And level 2, the learner is allowed to, and then you can read. Now there's one major thing that I still struggle with, and a lot of my colleagues struggle with, especially the supervisors in the clinical wards. It's the purpose of workplace-based assessment. And I want you to think about the question, should satisfactory completion of training be valued retrospective or prospective? So what I mean is that if you have a resident in the clinical ward and you give him a mini CEX about how he is doing the physical examination, for example, how are you going to value the entrustment that you give that person? Are you going to value it retrospectively? Then you say this resident or student has shown the mastery of the content, thought in causes and rotations as you have seen it when he was working. Or are you going to say something and value it prospectively? And then you say, is this student or is this resident ready to assess to assume the expected future responsibilities based on what you've seen at that moment? And of course, it's very difficult, and I understand that, when supervisors say, well, I know this resident has now done the right thing from what I've seen in clinical practice right now. But how can I predict if he's going to do it always the right way in a year or in 2 years, or when he gets another patient with a different disease that he doesn't know yet? And then my answer is always, well, I've been program director for 15 years, and I've been signing off hundreds of residents with my signature that they can be internists. And that's what I've always done, because I know the residents and I've been talking to the supervisors of how they perform. Never anybody put anything on paper about it, but we just talked about it. What we do now differently with EPAs is that we ask supervisors to write down, of course, talk to the resident, how they are performing, but they have to write down what they are doing right and what they should be better in. So now they have to be explicit. And they have to say, yes, I entrust this resident to do the job for the next week on his own. And whenever there's a problem, he just have to call me. So the funny thing is that with EPAs, we are more explicit about things, and that makes supervisors scared to do that. But in fact, we have been doing it the whole time already in clinical practice. Every day you think, resident, you can do that by yourself, and I will hear when you're in trouble. So I hope this makes you less scared to entrust residents for future responsibilities. But let's make sure that trusting someone always requires that you make yourself vulnerable. And we appreciate that, because that's when you're a good teacher and a good supervisor. Calculate risk that adverse events are acceptable. That's inevitable. Graduates will be certified to carry out activities that supervisors have not been able to observe and learners have never encountered. But that's how we train residents, and that's how we train medical students. And entrustment decisions require estimation of adaptive competence to cope with unfamiliar situations. I guess we have all experienced this in this COVID period, that we need to train and see that students and residents are able to have adaptability, because otherwise, I think that's an essential competence for doctors and medical specialists. Now, one sheet on ad hoc entrustment and summative entrustment. Ad hoc entrustment is a situational decision by a single supervisor for an individual learner in a given context. So let me give you an example. When I supervise a trainee on the ward, then I may decide after 2 or 3 weeks, in that period of time, I go with the residents every day in what he's doing. And then I tell the resident, well, I think for the next week, you're going to do the rounds by yourself for 3 days in the week. And if you doubt about something, just call me up and I'll help you out. So that's my decision in that context, that I take that decision to give the learner, the resident, I entrust certain activities to do by himself. And we do a lot of ad hoc entrustment every day, I guess, also in your clinical practice. Now, a summative entrustment decision is ideally made by a team. And then the team says that from now on, this resident can do this job with unsupervised practice. So that's a difference, because the learner can also think at a certain time, I have enough competencies required to perform a task. And now he will come to the program director, he will come to me and say, I think I can do that by myself the next time. And then I say, okay, let's go to your portfolio, look at all your evaluations and put in a request at the Clinical Competency Committee, who is going to make a summative entrustment decision. And so you gradually let the student grow in responsibility that he can take. So here you've seen this graph before. I hope you recognize it, of course. And here you see the growth of competence, and which is associated with decrease in supervision. And I put them in as shades. So here you go from observation only to direct, indirect, distant supervision, and no supervision. Now, what I want you to see in this example is that the summative decision for unsupervised practice is when the resident is still in training. So that means that the resident has a period of time during his residency training that he can do a task with having his own responsibility and experience what it means to have your own responsibility. And there's actually a lot of publications that show now that because of patient safety issues, we tend to leave the residents with their own responsibility to do something, because we think it's not allowed, because the learner is still in training. But in my experience, and there's publications over that too, it's very important that during the residency training time, the resident gradually is exposed to more and more being responsible, because then he can feel how it is to have the responsibility, with the backup of knowing that there's always a supervisor available. So I think it's better to train this responsibility during the residency training program instead of delivering young doctors who find it very difficult to have full responsibility once they get their certification. So I think I've been boring you maybe with a lot of talk of my side. So now Malika will show you what we've done in the Netherlands by a video.
Okay.
I stop share then, right? No, oh, you did it already. Okay.
Now I'm sharing, yes. Yeah. Oh, sorry. Yes. Yes, here it is.
Becoming a medical specialist primarily happens through learning in practice, by observing, by exploring details, and by gaining broad experience in a supervised learning and working environment. The daily professional activities of the specialist form the building blocks of the training. Experienced educators and residents have translated the professional activities and the required competencies into EPAs in order to constitute a curriculum. These are entrustable professional activities. These are the core professional activities that residents need to master. They perform these during the training and ask for feedback and assessments in order to demonstrate their competence. Residents start working under supervision and gradually proceed to work more independently once supervisors trust them to do their work. By dividing the training into units that can be assessed individually, the residents can be entrusted with EPAs when they are ready for it. This also means, for example, that residents with adequate knowledge and relevant work experience can be awarded an exemption, and residents are able to complete parts of the program sooner than scheduled, giving residents who excel more opportunity to develop a profile. However, it may, of course, also take longer if the resident needs more time to complete training segments. The training plan offers educators all the tools for certifying that residents can receive summative entrustment decisions for the various segments. This allows for individual learning pathways to be discussed and scheduled. The training duration is determined by the time required for the resident to acquire the complete package of summative entrustment decisions, to complete all the training components, and to develop a profile. Through individualization of postgraduate medical training, we can adapt the program to better suit the experience, the learning speed, and the ambitions of every individual resident. And so preparing today's resident for the care demands of the future. The training process will also become more transparent. Training time will be used more effectively, and the quality will be guaranteed. This makes postgraduate medical education as long as necessary, as short as is responsible.
Yes, now you can share, Dr. Graf.
Okay, so I go back. My screen, yeah. Okay, this is what we made for the introduction of our EPA-based programs of all residency training education. Oh, wait a minute. Now I don't want this. Excuse me. I pushed the wrong button because now I go into the, I'll go back. Yeah, I see it. This one I need. I pushed on the video again. That's not what we need. Oh, that's strange. It goes back into the, uh-oh. Am I still there? Yeah, I'm still here. But now I can get it back to my screen. Just hold on for a minute because I want this. Go back. Okay, I'll do it this way. I think I have it fixed. Yeah. So we come to the another important topic, namely how do you make an EPA-based program or curriculum? So I will very quickly go through what kind of activities are EPAs and the number and breadth of the EPAs in your program, and what are nested EPAs. So what's the logic of an EPA? Well, things can be EPAs. That's a question that is very, has very different and various answers. I already addressed that all EPAs must be activities, but of course, there is legitimate variation in what kind of activities. So you can conclude that for surgery, for example, that certain procedures are activities, like all the things you have to do with your hands. But for general internal medicine or pediatrics, it's more like disease management that you can define as an EPA. Now, what we have done in internal medicine in the Netherlands, we have defined roles or functions as EPAs. And one of the example is, for example, running the outpatient clinic, or running the ward, or doing consultations. And you have to make up the decision depending on the context you're working in. The choice that you make has implications. When you are defining a curriculum or a residency training program, then of course it would be nice if the whole domain is covered with all EPAs. Of course, it's preferable to have a national consensus, but we also see that's a challenge too. I'm coming from tiny little Holland, so we managed to have a national consensus. And sometimes you have to look also for hybrid solutions. For example, what was done in pediatrics in the Netherlands, that they also, as a big specialty with lots of diseases, they made the choice for going for an EPA as a function. So, for example, outpatient clinic for common pediatrics. But then the dilemma, of course, is, yeah, but how do we know for sure that all diseases and procedures are covered? Well, they choose not to use the disease as an EPA, but they said, we're going to do the EPA by observing outpatient clinics. And then the resident is asked in his portfolio to keep track of the list of diseases and procedures that he has performed. And of course, that's also reviewed by when you are going for a summative entrustment decision, and it's also reviewed by the program director. There's also a lot of questions about the number of EPAs in a program and how broad the EPA should be. And I just give you some general rules and indications. The higher the stage of training, the broader the EPAs. And this is an example. Inserting an IV, it's one narrow but very suitable EPA for a medical student, but of course not for a resident. Because for a resident, you go for an EPA like running the specialized outpatient clinic. That's a broad EPA that's very good for a senior resident or a fellow, but it would not be, and it would be too broad for a medical student or a junior resident. Now, in the last couple of years, there's been a development and new insight, and we think that the number of EPAs should be limited. Think of less than 10 per program per year, and less than 30 per program. For internal medicine in the Netherlands, we now have 25 different EPAs. For a 6-year, well, we don't have a fixed time duration, of course, anymore, for a 6-year training program. You just have to realize when you're going to develop EPAs that too many EPAs will decrease their significance for summative entrustment and also increase feasibility problems. It's the same as with the competencies. If you break them down to 700 competencies, you cannot work with them anymore. So you have to make a balance between the number and breadth of the EPAs, how that can be done in clinical practice. And you have to realize that small EPAs naturally become nested within broader EPAs later. And here I show you what I mean with that. If you are a junior medical student, you may have an EPA as measuring blood pressure. But when you are a senior medical student, then the EPA is a complete physical and history taking, which already includes measuring blood pressure. And an example for the residency training program, if you are a junior resident, the EPA can be management of uncomplicated patients. But for a senior resident, we go to the broader EPA of running a regular outpatient clinic. So in that way, the development and the definition of an EPA has to be in the growth of the development of a trainee during his curriculum or his residency training program. Now, I only have one slide on the description of an EPA, where we define 8 components. And I don't have the time to go into it. So I would like to refer to you to the AMI guide 140. It's already in press. And here you can read all about how you describe an EPA. And to give you an indication, for internal medicine in the Netherlands, the description of one EPA is about 2 to 3 pages. So we have, I already told you, 25 different EPAs. So we have tried to have a concise description of the needs for the standards of an internist in the Netherlands by not too many pages, I would say. Now, how do you come to the identification of valid EPAs? Here are some suggestions, but it's also depending on the context you're living in. To give you an example of how we did this in the Netherlands for internal medicine, I was the chair of an EPA committee, and I asked several residents and several program directors from all the different areas. We have 8 different areas in the Netherlands. And we had several brainstorm sessions, and we came up with concept EPAs. Then we decided to do a pilot, because we thought we get the best information if people are just willing to try it out in practice. So we had 18 hospitals, both at academic and regional hospitals, and they used the EPAs in 3 different rotations: intensive care, the general internal medicine ward, and during the evening and night shifts. And they filled in all the forms, and they made entrustment decisions for the residents for half a year. And then we did a survey, and we had interviews in all the different hospitals. So that was quite a lot of work, but it was a lot of fun too. And we got all the feedback on the EPAs and how they work and what definitely did not work. And based on that, we made the EPA program that's now launched since 1.5 years in the Netherlands. And we have to appreciate that it's a living, dynamic document, because we are changing it over time to upgrade it. Now, if you want to learn more about constructing approaches for EPAs, then I can also recommend this publication by David Taylor. And then I want to say something more about when trainees, that you have to include in the development of your program, when trainees are expected to reach which level of entrustment or supervision for an EPA. Now, if we look at the whole world where EPAs are used, or not EPAs, but what the need is for when you graduate somebody. And then in many countries, you see a level 3, so that's indirect supervision at the end of medical school. But I have to say there's also variation, and in some countries, even if at the end of medical school, they think the doctors can practice unsupervised. But then as a country, you have to decide what your limitation is. In Holland, we say when you graduate from medical school, you are on level 3. And if you are at the end of the residency training program, then you are at level 4. But it's not that I'm saying somebody is right or wrong. It's more that you have to have the dialogue about it. So you have to map the EPAs over the course of the training. So postgraduate year 1, 2, 3 is on the top, and then in the vertical line, the different EPAs. And then you can give an indication of when you expect for a certain EPA to go to unsupervised practice. In what year, and then you can also say in what rotation. And this is very valuable both for the learner and for the supervisor. Because if the learner feels that he is competent enough to perform unsupervised, then he can ask the clinical competency committee to get his summative entrustment decision. But if a supervisor knows, oh, this resident is going a bit slow because I expected him already to be unsupervised, but he's still not, then you know you have to talk to somebody and make some activities that you can guide him more closely and make sure that the growth of the competence proceeds by a resident. Now, if competency-based education draws more on competence than on time, then assessment, of course, should be very high quality, because we don't have time. Your time is up, so you have to go. No, we say, do you need the standard? Are you at the standard? And then I will let you go. So are we satisfied with our workplace-based assessment? Well, I think there's still need for improvement. And I want to show you how entrustment can improve workplace-based assessment. Now, maybe you recognize this, the psychology of a traditional workplace assessment. Here is a resident that says, oh, please, that thinks, oh, please, mark me superior. And this is what's then thought by the supervisor. She's nice and she works hard and it won't hurt and will probably motivate if I mark her superior. But then we think, when we take entrustment into this decision, bring the patient into this equation. And why is it so important to bring the patient in? Because then the supervisor will think, she's nice and she works hard, but it may hurt my patient if I mark her ready for unsupervised practice. So when considering entrustment decisions, there are several factors to take into account. I've listed them here. You can read about it, and I wanted to say one thing more about learner factors. Usually when we look at a resident in clinical practice, we put a lot of energy in talking about his capabilities, like the knowledge, the skills, the experience, situational awareness. And I think we should more appreciate, when we talk about entrustment, about other qualities of the learners. And here I show them to you, and we are talking about a rich entrustment decision, because we would like you to consider to take into account reliability, integrity, humility, and agency into the entrustment decision. And here I show you what we think you should take into account. It's like, does a learner feel accountable? Is the learner predictable? Does he show integrity, like truthful, patient-centeredness? Does the learner show humility? Does he recognize his own limitations? Does he ask for help? Is he receptive to feedback, etc., etc.? I think these qualities are basic qualities for professional behavior. And it's not failure that is fatal, but failure to change that might be. So we have to make the residents aware how important these personal competencies are. So I'm getting to the end. I want to mention one thing about workplace-based assessments. I think you recognize this look, that you work with the residents in clinical practice, you make observations, you do evaluations, and you provide feedback to the residents. And that's a circle that goes on. And all the observations that you talk about with a resident, you also put them in writing in a portfolio. And then after a certain amount of time, or the supervisor, and actually I hope both the supervisor and the resident, they feel like, I'm ready for a summative entrustment decision. And then, as I told you, a team can be established. We call it a clinical competency team. It consists of the program director together with supervisors, and they look at the portfolio data and they can make the decision of making a summative entrustment decision. And you probably got tired of my voice already, so I have one other animation video to explain to you how we do the summative entrustment decision.
And it's coming. Oops. Yes.
Postgraduate medical education prepares residents for the work that they will perform in practice. This training is aimed at what a newly qualified medical specialist should know and be able to do. In the training plan, all professional activities are elaborated as Entrustable Professional Activities, also called EPAs. This describes the knowledge, skills, attitude and behaviour that are important in the execution of the EPA and which tools can be used to assess this. If the resident is able to perform the EPA at level 4, which means with distant supervision, a summative entrustment decision can be made. In this animation, we will explain how the summative entrustment decision making works. Firstly, the resident discusses with the clinical educator the set of instruments that they will use for observation, assessment, and feedback. This gives the resident and the educator a clear impression of what the learning pathway will look like. The resident then gets to work and collects feedback and assessments. In order to demonstrate competence, the resident submits proof of achievements to the Clinical Competency Committee. The committee or team will then meet to discuss the progress. Each of the members has observed the resident from various perspectives. They include the day-to-day experience with the resident in the clinical workplace and the accompanying gut feeling. Based on the confidence that they have in the resident, the Clinical Competence Committee decides how much supervision is required. We call this the level of supervision, from observation to performing tasks independently with direct or indirect supervision, to supervision at a distance, and providing supervision themselves. The resident receives feedback from the clinician educator. The entrustment decisions are documented and motivated in a portfolio. As the competence of the resident increases, so the educator's trust in the resident increases and the need for supervision decreases. This results in the resident completing an increasing number of tasks independently. Once the resident has demonstrated the required competence to work under distant supervision and has gained the trust of the Clinical Competency Committee, then they will decide together to take a summative entrustment decision. Having earned the summative entrustment decision, the resident has all the competencies required to perform this professional activity independently. Once the resident has received summative entrustment decisions for all EPAs and has passed all the training segments, he is allowed to call himself a medical specialist. A good approach to summative entrustment decisions making stimulates residents to increase their level of independence, backed by the trust of the committee and team.
Yes. Now your turn, Dr. Graf.
Yeah, I'm working on it. Well, actually, I'm coming to the end of my talk, and I just wanted to tell you that if you're more interested in more in depth, because I only touched this the subject on I touch on the subject, then of course I can only recommend to you the international EPA course that's led by Olle ten Kate, and I'm very proud to be one of the faculty members that's also participating in this course. And we just made an online version because, of course, last year all EPA courses were canceled. So if you're interested, just let me know. And thank you for your attention. And I hope you will all keep 1.5 meter distance, as we say in Holland, and stay healthy. And I'm happy to go through any of your questions. I already looked at the chat, but Kemal, you have to help me out because a lot of them are in Turkish, and unfortunately.
Okay, thank you very much for your presentation. It was really informative and stimulating for me and also for the audience, I'm sure. There are so many messages you see in the chat box. And as you see, many of them are in Turkish. Actually, they are about the key points in your presentation, direct translation of your key points into Turkish. There are not any comments or questions. But as far as I can see, there are some commands, if I can find.
I think Kemal Sevgi won.
Okay, so Çiğdem brings a comment. She says, when we talk about a successful critic, we always say, do not criticize the person, but criticize the behavior. I think EPA took that approach brilliantly and applied to practice. So I think you agree with this comment.
Yeah. Yes.
Yes.
Yeah, and that's. I think it's. I think in EPA and in every training program, feedback is the major challenge of communication between people. Because if you want to give feedback, we are always very hesitant to make negative feedback. But actually, if we want to improve somebody, you need the learner to be open for feedback as not being critical to his person, but to developing a good professional attitude. So it's always, I think feedback is the major thing that should be safe. And if that's not the case, then whatever system you choose, you can never educate a good professional.
Yes, you're right.
And we have to be all role models. I mean, I just think about, am I giving good feedback to my own colleagues? And do I say, well, maybe there's another way of approaching this, or maybe you can say this differently to a resident. If we are in a handover situation, sometimes they can be very blunt. And I've learned myself to say in public, is there also another way of addressing a point that a resident can do better? But it's difficult. We think it's easy, but it's not.
Okay, okay, thank you. Another brilliant contribution from one participant. I don't know if it's possible to show this, but I can explain what it says. You know, Miller competence pyramid, and actually in its original form, there are 4 levels, starting with knows, and then knows how, and shows how, and finally does. And our participant adds another 5th level to this pyramid as being entrusted.
I don't have anything to to add. I totally agree.
A very smart approach, I think.
Yeah, totally agree.
So I'm just trying to navigate between the messages. Okay, that's the pyramid you see.
Yeah.
Yeah, very smart.
Perfect. Yeah, perfect.
Okay.
Thank you for that.
Okay. And another comment from one participant, she says she has a concern, maybe due to she's new to this topic, that an EPA program may does an EPA program lead mm, late graduation for minority groups. For example, prejudice may be a reason to decisions, I mean, entrustment decisions. I think no, but have you ever experienced such situations?
So let me see if I understand. You're asking the question whether there's a possibility of later graduation?
For minority groups.
Yeah, we do. Actually in Holland, we have also a change in the law that there's no fixed duration anymore for medical specialist trainings.
Mhm.
So it's only the European minimum years. So for internal medicine, for example, we have 5 years. That's the European minimum. But in Holland, the internal medicine training was 6 years actually. So what we do now is that there is a fluctuation in the duration of time for an individual between 5 and 6 years actually. And for now, we see that the majority of residents, that's about 80%, goes with the average time, and that there's 10% that go quicker, and there's 10% that go that takes more time. And they take more time, and we have a special procedure that has to be taken. The program director has to ask the official department to get an extension of the duration of the time of an individual resident. And then this resident gets a special program that there's more, he gets a tutor and a mentor to have a more close observation. So the growth of the resident is really registered. And then you can get more time, and that's about 10% or less of the residents that need more time. And in general, 3 months less training is among the 80% of the residents. So 80% has 3 months less education time.
Okay, thank you.
That's the numbers we have now in the Netherlands.
Thank you. Another comment from Sevgi. She says, COVID-19 pandemic shows us the importance of the EPA once more. The design of the EPA based on the trainees' individual learning needs, such as needs for more time or practice. However, as we see during COVID-19, institutional or organizational needs also require to description of the EPAs. Thank you. It was a great presentation. That's the comment from one participant. I think another comment is coming. Thank you very much, Professor Dr. Jacqueline de Graaf. And my question is concerning the validity of assessments you described, how you have handled or tried to handle. Indeed, there are a lot of criticisms concerning assessments. For example, in the table titled Growth of Competence, you showed an order from novice to expert. How you reduce the human factor bias in assessments? Possible.
Oh, definitely. What I just said about feedback, it's, of course, there's always a personal interpretation of how you judge a resident. We have done workshops actually with lots of supervisors that we show a movie of how a resident is doing in the emergency room with a patient. And then we have a worksheet and then they have to fill in what they should say to this resident, what they do good and what should be better, and how they should judge, how they should have their final assessment about this resident. And there's variation.
Mhm, mhm.
And that's inevitable. And really, it was so nice to do because you learn from each other as supervisors. What do you think is important to act as a professional? And then you will see that even within your own group of supervisors, there will be diversity. And I think it's an amazing opportunity to talk about it with each other. No COVID.
Okay, okay.
So I think that the value is that the resident gets feedback of many different supervisors. And that's the way to learn from each other, to learn between supervisors, but also the residents sees a lot of different role models. And the residents learn from each role model something different. So it's not one assessment, it's not one opinion that makes an assessment of a resident. It's a lots of opinions that make the assessment of a resident.
Mhm.
You
Okay.
understand what I want to say?
Okay, okay. And there are some messages about how the participants are thankful to you for your presentation. And also there is another question asking, have you defined EPAs for medical teachers?
So are you referring then to faculty development?
Maybe, maybe.
Because if you define an EPA, then you have to also, for faculty members, then who is going to assess that?
Mm-hmm. Mm-hmm.
So no, in that respect, no, we don't have an EPA for faculty. It would be interesting though to think about that now that you say that, but we do have a faculty development program, especially how to act as supervisor in an EPA-based program.
But you don't have any EPA-based program for faculty development, I think.
We do have, for example, in the Radboud University and all university medical centers, all specialists who are also teaching for students or residents, they have to have a certificate. So they have to do a training, but it's definitely not EPA-based yet.
Okay, okay. I think there's another question, especially postgraduate trainees take part in real practice. Many postgraduate programs currently have a rating like novice, interim, senior, chief for residents who have different level responsibilities based on their knowledge and skills. But this classification was in need of its theorizing and determining its criteria because postgraduate trainees may have the important responsibilities corresponding with their practice at the malpractice cases. What do you think about whether EPAs and programs entrustment decisions will be used against or in favor of clinical programs and their residents at malpractice cases in future? It's a long.
Yeah. I don't know if I get the question because it concerns malpractice. That's what you...
Yes, yes.
Can you rephrase it one more time, please?
So using the EPA's approach, can we prevent some kind of malpractices in our clinics, for example?
Can it prevent malpractice? Well, I think that refers maybe to the slide that I also said that of major importance is that the residents in their last 1 or 2 years of their training program, that they get responsibility to act with distant supervision and supervised practice. I think if you do that in a situation that a resident feels that he still has the backup of a supervisor, then he gets more responsibility training. And does it prevent malpractice? I think the main thing for malpractice is reflexivity and adaptability, actually.
Mhm,
You have to be honest to yourself.
mhm,
What can I do and feel confident with? And do you have the guts to tell your colleagues or tell your patient, I don't know, and I'm going to find out for you, but I cannot do it right away, and I cannot give you the answer right away. And that's the attitude that we have to learn and that we have to share in our community of professionals as doctors and as medical specialists. We have to feel safe to say, I don't know. And if you do that, then at least you have the chance to not go into malpractice.
mhm.
I think that's a major thing we have to learn our residents. And then we have to be role models again to do that.
Okay. So is there any change in malpractice cases in your clinic after adopting the new?
Yeah, that's too soon to ask, because it's the last 2 years that nearly all programs are now EPA based for all specialties, but it's not long enough to have fully implemented. I mean, the national programs have been written EPA based, and now we are putting it into implementation.
Okay.
So it's too soon. Maybe in 1 or 2 years we can say more about it.
Okay, thank
Need
you.
more time.
And the final question is, I think that faculty are the biggest issue in transition to the CBME EPA curriculum in graduate medical education. How did you handle faculty during your transition in your department? Because it brings a huge workload to the faculty, to be honest. Okay.
Yeah, totally agree. Because of course, the program directors, they are the dedicated persons who really want to go for their residence, and then the faculty, the supervisors in the working place, they are crucial. I mean, if they are not that involved in the whole EPA entrustment project, then I can be very enthusiastic, but nothing happens on the working place. And that's crucial. So what I've done is taking them with me from the start. I did not develop the whole thing and then say, here you have it, I'm the program director, so just do it like that. No, when we started with this, I had once a month, when I started with the national committee, once a month in my own hospital with my own staff, I said, look, this is what we're working on. What's your input? How do you think about it? What hurdles do you see? You have to make them partner from start to make sure that at the end you can really implement it. But it's a major challenge, I can tell you that. And if you have a solution about that, how you can do that, please let me know, because it's a challenge.
Okay. Okay.
Yeah.
Thank you. I think there is no other question, and we are getting closer to the end of our time allocated for us. So I would like to thank to you for your kind contribution to our Congress. Hopefully in the future, we will come together in real world meetings, and we will be honored to host you here in Turkey in other meetings. Thank you very much for contribution.
Well, thank you for the opportunity that you gave me, and it's been my honor. Thank you very much.
Thank
And
you.
stay healthy, everybody.
Thank you very much, Kemal, and thank you very much, Dr. Graf. It was really a great presentation. Now, nobody leave the meeting, please. We will have a Congress photograph, but you know, it is not easy to take a Congress photograph. So, sorry, Dr. Graf, don't leave the meeting, please. I will turn to Turkish with your permission. Sorry for that. Şimdi, lütfen herkes yerinde kalsın. Kamerasını açabilenler lütfen açsın. Açamayanlar lütfen açık adını yazsın. 6 sayfasınız. Ekranda 25 kişi var. Sırayla print screen yapacağım. Onun için lütfen sabırlı olmanızı bekliyorum. Şimdi Barış'cığım sen de bu arada gelenleri hızlı hızlı alırsan diğerlere hiç olmazsa şey yapmış olsunlar. Birinci sayfayla şu anki sayfayla başlıyorum. So be ready. Okay. First page. Sonra bunu PowerPoint'e aktarıyorum. Bilmiyorum, belki başka bir yolu vardır ama benden bu kadar. Geri dönüyorum. İkinci sayfaya geçiyorum. Evet. Herkesin hazır olduğunu umuyorum. Herkes hazır olsun çünkü sayfada kimlerin olduğunu söylemem çok zor. Evet, güzel görünüyor herkes. Print screen. İkinci sayfayı da çektim. Hop, hop, hop. Evet, üçüncü sayfadayım. Herkes baksın. Evet, isimler var burada. Çektim. Hop, hop, hop. Tamam. Dördüncü sayfadayım. Hazır mısınız? Evet. Bunu da çektim. Evet. 5. sayfadayım. Onu da çektim. Artık görüntüler azalıyor nedense. Kameraları kapalı herkesin. Umarım buradalardır. Yakalandılar. Evet. 6. ve son sayfadayım. Ops. Evet. Yes, now I'm again at the first page. Thank you very much to all of you. Bu oturumu da tamamladık. Saat 3'te forumla bir arada olacağız. Tıp eğitiminde öğretim teknolojisi kullanımı, deneyimler, ipuçları ve yeni arayışlar. Saat 3'te tekrardan bir araya gelmek umuduyla. Thank you very much, Dr. Graf. We all are leaving this session.
Okay, thank you very much.
Again in Istanbul, in Turkey.
Okay.
Teşekkürler Kemal'cim sana da bütün katkıların için. Hoşça kalın. Barış, kapatabiliriz. Bye bye.